Hey June, I just wanted to check, does this look okay on y'all's end?
Yes, we can see that, Cody. That looks perfect.
Okay, cool. I just wanted to make sure that it wasn't doing anything funky, like trying to jump into presenter view or anything like
No, that looks good. Thank you for checking.
that. And I guess you can hear me, mic's okay and all that good stuff.
Yes, Mike sounds good.
Awesome.
Hi, Cody. Nice to see
How are you,
you.
Dr. Kirk? Good to see you.
Hi, Carrie.
Hi guys.
Well, thanks everyone for joining. We're going to get started as soon as it clicks over to 7:15. I mean, to 12:15. Goodness, I'm on the wrong time zone. Junie, I really like this picture.
Thank you. I picked it myself.
Yeah, I
I was
like
just about
that.
to say the same thing. It's beautiful.
Yeah.
From where did you pick it, Junie? Where was
We have a Getty Images subscription here at the school. I by no means took it myself or anything like that.
Well, I want to be a drone farmer, so I'm going to claim that I took this flying over my ranch back in Oklahoma.
Perfect. We'll say
That's
that.
what we'll say from now on. How about that?
Sounds good.
Okay. And our other Cody, yes, we've got the speakers here. So I'm going to go ahead and jump in and say thanks for everyone to make time and join us. Good afternoon. We're here to continue our discussion on rural health, with today's topic being addressing challenges in rural health care access. As background, the school started this rural health initiative. It really grew out of discussion several years ago, with recognition that despite the extensive global research and practice portfolio that we have, our engagement and activity in rural domestic US settings was notably more limited. Last year, we formalized these efforts as part of the Rural Health Initiative, and the goal really is to get people to talk and collaborate amongst our community within this topic. And we've had a very robust response. Lots of people joining the previous seminars, both in person and on Zoom. And as we did in our first Zoom seminar, I'm going to ask that the those of you on just drop your name and affiliation into the chat and a couple of keywords about your interest or expertise related to rural health. We want to keep in touch. We have your name and email from registration, but we like to grow our list of interests and experts. So I'm Greg Kirk, Vice Dean for Research. Like many of us, I have rural roots and did grow up on a ranch in Oklahoma. I'm interested in urban-rural differences in infectious diseases and substance use. So you guys could put something like that in the chat. We're very fortunate today to have two prominent leaders in rural health advocacy and access. And we have a Kody from Michigan and a Kody from North Carolina. And when we confirmed the dates, both of them used the term y'all in the email to respond that they were agreeable to join this presentation. So I think we're going to have a great session, but I'm going to hand off to Carrie Altoff, professor in Epi and chair of our data council, and also a native from a farming region in Iowa, to moderate the discussion. So I'm going to hand it off to Carrie.
Hello, everyone, and thank you, Greg. I am still riding the Iowa Hawkeye high from the amazing work the boys basketball team did in the tournament going on. I was in Greece last week for meetings, but absolutely spouting and wearing all of my Hawkeye gear as they shocked everybody, knocking out #1 Florida and continuing on, eventually getting bumped out by the University of Illinois. But they're our neighbors, so we'll deal with that. But welcome everyone today to this great session, and we're so excited to have two Kodys with us. So of course, being a scientist, you get a little curious. So I started digging on the name Kody. And the name Kody is actually an anglicized form of the Gaelic surname McOda, meaning son of Oda or son of Otto. And while it was initially a surname, it gained popularity as a given name in the United States during the late 19th century. This was largely due to the fame of Buffalo Bill Cody, the American showman and Army scout who popularized the Wild West shows. So hugely important name and tied to the Great Western culture. It surged in popularity during the 1970s and 1980s in the United States. It reached its peak in 1992 when it ranked 22nd among male names, according to the U.S. Social Security Administration. And over time, Kody has established itself as a very distinctly American name with historical connections to the frontier spirit and the Western heritage. So we're glad to have Kody and Kody with us today. To get started, I will begin by introducing Dr. Cody Mullens, and then he will give a few remarks. I encourage you to put all of your comments and questions into the chat during Dr. Mullens' remarks. And then I will introduce Mr. Cody Kinsley, former secretary, and we will have remarks from Kody, and then also put more comments in the chat, and then we'll have a discussion. So it's my pleasure to introduce to you Dr. Cody Mullens, who is currently a general surgeon at the University of Michigan and a research fellow in the National Clinical Scholars Program, focusing on studying access to and quality of surgical care for rural patients. Cody completed his Bachelor's of Science and MD from from West Virginia University, and his MPH from the University of Pennsylvania, along with the Master's in Health and Healthcare Research at the University of Michigan. Cody is currently a Rural Health Policy Fellow at the National Rural Health Association, and he serves on the Advisory Council for Rural Surgery at the American College of Surgeons. His research interest is improving in studying the unique challenges in the delivery of surgical care for rural patients and improving access, quality, and cost of surgical care for rural patients in the United States. So welcome, Dr. Mullens. And again, please put your questions in the chat, audience members. Take it away.
Awesome. Thank you very much. If y'all don't learn anything from me, you guys got a masterclass on the history of the name Kody, if nothing else from today. I am going to pull up or attempt to share my screen here. Would you guys mind just confirming that the slides look normal to you? It's not in presenter view or anything weird like that?
They look great.
Awesome. So thanks again for the introduction and for the opportunity to speak with you all today. These are my disclosures. None of them are relevant to what I'm talking about today. So today, what I hope to do in the next 20 or so minutes is focus in a little bit on rural health policy, specifically with some broader historical context. And after that, we'll talk about some of the current challenges facing rural health. specifically examining surgical care at rural hospitals and surgical care for rural patients. There we go. This is the first time that I'm actually including this slide in a talk, but the top quote is sentiment that I've heard not infrequently when discussing inequities in rural healthcare. I think the suggestion that if rural patients want better healthcare, they should just go to the city holds about as much water as suggesting that folks in the city should move near a farm or near a coal mine if they want access to food or to power. Stepping back, I think this notion and intention kind of underscores a reality currently in rural America that many have misconceptions about the role that rural plays in broader society. Despite rural areas and the people that live there providing the work to literally fuel and power our economy through hazardous work that they do, those who reap the most benefits from this work severely underappreciate how and where the resources they consume were actually produced. Thinking about it a little bit more, we have literally built, the supply chains, grocery stores, and actual farmers markets in towns and cities for food supply and develop the infrastructure to deliver power and fuel to meet people where they live. But to me, this kind of in turn begs the question of why we shouldn't work to improve the built environment locally to improve and sustain rural folks' health. Now, if you can't tell from those opening remarks, I'm a little bit biased, so I'll just explicitly acknowledge that. I grew up in a small steel mill town in West Virginia where 3 generations of men before me all worked in the steel mill. This hospital is my hometown hospital that covers 2 of the northernmost counties in West Virginia, and is where I was born, where my grandmother worked as a nurse's aide, and where my mom worked as a nurse as well. I only considered becoming something different than a steel mill worker or a coal miner because I happened to shadow the one rural general surgeon in my hometown, Dr. Sam Licata, because my mom happened to go to high school with him and I was required to do 3 different forms of job shadowing in order to graduate. This photo was a full circle moment as a 4th-year medical student. I got to do a rural surgery rotation with him shortly before matching at U of M for my surgical training. And a lot has happened between then and now, but it's kind of brought me to where I am today in a lot of ways and inspired the scholarly side of my professional mission as a surgeon, which is to better optimize the delivery of timely, high quality, and affordable surgical care for rural patients. Now, I want to briefly touch on rural health policy at a high level. I know the other Cody is going to zoom in on the Rural Health Transformation Fund as a timely and current policy example that's influencing rural health. But at a high level, I would contend that the vast majority of rural health policy that's been developed has been unintentional and more reactionary in nature rather than being proactive with foresight. These examples date all the way back to the Hill-Burton Act of 1946 that had to create a specific carve-out to support rural hospitals construction, rather than just hospitals that were going to be built in bigger cities and metropolises. The Balanced Budget Act in 1997 was going to cause a disastrous fallout for lower volume, small rural hospitals if implemented as it was, and that led to the creation of the critical access hospital designation. And then the most recent policy example that Cody's going to take a deep dive into is the Band-Aid that the current administration applied for rural healthcare in the form of the $50 billion Rural Health Transformation Fund. And these 3 larger policies have all occurred in the context and backdrop of a number of other federal policy decisions that have substantially influenced rural health that we don't have time to get into in detail today. But before we jump into access and quality of care for rural patients, I think it might be helpful just to give a little bit more specific context. I know it's something y'all have been thinking about recently, but just want to highlight some of the key challenges facing rural health. The challenge that's most likely apparent to everyone on the call is that of rural hospital closures, which are largely occurring due to financial vulnerability. Fairmont Regional Medical Center is a hospital in West Virginia that I did my first clinical rotation at as a medical student, and where I got to assist in delivering a baby for the first time. And the hospital closed a couple of years back, but actually more recently, funny enough, reopened after being purchased by WVU Medicine. But closures like this are more often permanent in nature and have been happening all across the country, especially in the Southeast, with nearly 200 rural hospital closures in the past 20 years. And we've learned a number of lessons from the most recent wave of rural hospital closures, including that they're recognized as leading to increased travel times for affected populations, reducing access to hospital and emergency care, and they actually go as far as to harm local economies. And these closures also have disproportionate negative impacts on socially disadvantaged and traditionally underserved patient populations. Now, many rural hospitals face a delicate balancing act, working to preserve access locally while also ensuring that they the care that they provide is of high quality despite being in a resource-constrained setting. And this balance has to be struck while also mitigating multiple ongoing challenges, including workforce challenges, pressures to join hospital networks, or shut down inpatient services altogether and become a rural emergency hospital. And providing surgical care is also uniquely challenging in this context because of the multiple provider teams that are needed to deliver surgical care, the need for OR infrastructure, as well as the expensive equipment and overhead that's needed to preserve surgical care in these lower volume settings. So to zoom in on the current state of rural hospital quality, specifically in the context of surgical care, that's what we'll do here next. You might wonder why study rural hospitals and surgical care. Well, the provision of surgical care, as we mentioned previously, is expensive and requires a lot of resources, but it's generally reimbursed pretty well and tends to be a revenue generating and positive margin contributor to rural hospitals and their bottom line. And while it's a bit challenging to tease out the specific role that surgical care plays in the financial health of rural hospitals, we have some preliminary data from CMS cost reports that would corroborate this and suggest that it is indeed true that both inpatient and outpatient surgical care contributes in important ways to the financial health and viability of rural hospitals. A few slides ago, I mentioned the critical access hospital designation, which is probably the most widely known designation, or rural designation, probably because it's also the most prevalent one, as it represents around 1,500 hospitals in the US. To be a critical access hospital, you have to be located in a rural area and be a certain distance from other nearby hospitals. You also must have 25 or fewer beds, but also be able to provide 24/7 emergency care, inpatient care, as well as outpatient care. Now, being designated as a critical access hospital gets hospitals some enhanced federal financial reimbursement for the care they provide for fee-for-service Medicare beneficiaries, and also has some annual payouts from CMS. And so you might wonder what care might look like in a small rural hospital like this from a surgical quality standpoint. A 2016 JAMA paper by my primary research mentor, Andrew Ibrahim, evaluated common general surgery procedures like appendix removal, gallbladder removal, colon resection, and hernia repair. And they compared these small critical access hospitals to non-critical access hospitals, and they found that critical access hospital quality of surgical care was similar, if not slightly better than that of non-critical access hospitals across a number of different outcomes like mortality, complications, reoperations, and readmissions. Now, this paper also came out around a time where everyone was thinking about centralization of care and volume outcome relationships. And the authors of this paper found that critical access hospitals were able to provide this high quality surgical care despite providing substantially lower volumes of that care. And more recently, we were curious to investigate how critical access hospitals and their surgical care quality has changed over time. And we've actually found that across most measures, critical access hospitals are improving their care, the quality of care they provide surgically, likely in alignment with secular trends, but doing so at the same rate as their non-critical access hospital peers. And again, this is for common inpatient general surgical procedures with no previously described volume outcome relationships. We took these data in critical access hospitals a little bit further to look at common general surgery procedures among children. We hypothesized that a very small proportion of the pediatric population would undergo procedures like appendix removal or gallbladder removal in this setting, but we're surprised to see that it was as low as it was, which was around 1.1% of kids. But the quality of care is measured by complication rates and length of stay were not worse in the critical access hospital setting. We think what might be driving this very low proportion of cases occurring in this setting might actually be related more so to provider factors, with inpatient provider teams and anesthesia teams potentially being uncomfortable managing young pediatric patients in the smaller, lower resource setting. But regardless, we think it represents a potential opportunity to right-size surgical care delivery for kids and their families, especially for older kids, and those with less medical complexity, and not to mention the fact this would bring additional volume to these small rural hospitals that are struggling with maintaining overhead and the volume of care that they provide. But some interesting context about these findings is they're a bit of a contrast to the literature on care quality for medical conditions like heart attack care, heart failure exacerbations that have been studied previously in the critical access hospital setting. both on a cross-sectional basis and evaluating longitudinal trends over time. Care quality actually tends to be a little bit worse or equivalent for the medical conditions that are very common, but equivalent, if not better, for surgical care. So a little bit of a dichotomy there. Now, we dug into this nuance a little bit more, and there's a lot of nuance within those general findings, depending on the disease state that you're looking at or the outcome that you're measuring. This is a takeaway table from a scoping review that we just submitted an R&R for at the Journal of Rural Health that broadly evaluates inpatient care quality in the critical access hospital setting. And some of them, to put a finer point on what I just mentioned, in some of the most highly cited medical papers, pneumonia and heart failure care quality was actually not all that different between critical access hospitals and non-critical access hospital settings. But the main driver of differences were actually the most severe outcome measures like mortality after kind of the most time-sensitive care conditions like myocardial infarction or heart attacks. For surgical care, our takeaway was kind of that common surgical procedure care quality is similar in critical access hospital setting, but the care quality that has been studied for complex operations like liver and pancreas cancer surgery, unsurprisingly, tends to be worse in the critical access hospital setting. But in summary, I would contend that critical access hospitals broadly serve their purpose that they're intended to, which is delivering commonly encountered care with high quality. Though I would argue that their performance tends to be a little bit misunderstood when the structural differences are ignored and unaccounted for, and they definitely need our ongoing support. So far, from a surgical standpoint, you might be looking at these data and step back and say, hey, things like actually look pretty great in rural hospitals. And while I think that's directionally correct, I think there are also some very real challenges. We recently did some early work to evaluate the impact of rural hospital closures on surgical quality and access for common conditions using a difference in differences approach. In the study group being Medicare beneficiaries who lost their nearest by hospital versus those who lost their second nearest by hospital. So we could try to truly understand the impact of losing your nearest hospital on access to and quality of surgical care. From an access standpoint, we observed statistically significant increases in travel distance for beneficiaries to obtain care among those who lost their nearest hospital. But for quality of care is measured by outcomes like we've talked about previously, mortality, complications, reoperations, readmissions. Those were unchanged when we compared the pre and post time points across the group that lost their nearest versus second nearest hospital. And so these data would suggest that the closure of hospitals may not worsen surgical quality for common conditions, but it does widen the access gap. Now, this is a contrast to what's been described previously in the medical literature for their time-sensitive conditions. But if you think about it, in care for heart attacks, they kind of just operate on a fundamentally different timeline and level of care and time sensitivity than common surgical pathologies like acute appendicitis and acute cholecystitis. Switching gears a little bit, private equity's presence in healthcare has grown substantially in the last 20 years, with nearly 500 hospitals now being backed by PE entities. And there have been growing concerns about quality of for surgical patients after private equity investment, both evaluating common general surgery procedures like appendectomy and cholecystectomy and complex operations like esophagectomy. Rural hospital markets have been no exception to being subject to the wave of private equity entering healthcare spaces. Recent estimates suggest that PE firms now own over 130 rural hospitals, and there are growing concerns about the moral hazard this may be causing given the vulnerability of rural patients and the rural hospitals that serve them. When we looked at nearly 50 rural hospital closures that have been acquired by private equity, nearly 100,000 treated surgical patients, we found some early evidence of significant increases in 30-day mortality, complications, and serious complications. But when we did this analysis, one silver lining that we were pleased to see is that none of the PE-acquired rural hospitals have subsequently closed their doors, and all of them continue to provide some inpatient medical and surgical care. So these data identify some early evidence of eroding surgical quality after PE acquisition, which we think underscores the need for continued close monitoring of these acquisitions and highlights the need for consideration of regulator oversight. So to summarize these hospital data, I would argue that rural hospitals are capable of delivering safe, high-quality surgical care with outcomes comparable to larger centers for common general surgery procedures. Rural hospitals' strength lies in focused care that are high-value services like hernia repairs, endoscopy, appendix removal, rather than a broad subspecialty depth in highly specialized care. Now, moving on to thinking about access to and quality of surgical care among rural patients themselves compared to their non-rural counterparts. Oftentimes, rural facilities and rural patients and their quality of care and access to care kind of get lumped together and misconstrued. But as we'll soon see, the story of rural hospitals and care quality in the rural hospital setting doesn't necessarily tell the full story of quality of care for rural patients who might be receiving care elsewhere. Now, stepping back, the prospect of simply defining access to care is about as challenging and multifaceted as trying to come up with a singular definition of rurality. But I'll give you my like simple country surgeon's take on access in the context of surgical care. Now, previous assessments of surgical access have looked at what we think are the three most important aspects, which are through the lenses of timeliness, quality, and affordability. But these have all been studied separately in individual silos rather than in concert with one another. To understand access more broadly, we think it might be best to kind of view this through a combined lens. So to better understand access, we devised a stepwise model starting at the US population level and using data from multiple federal sources like CMS, the American Community Survey, the American Hospital Association. We use these data to have specific criteria for hospital capabilities, timeliness of care, quality of care, and affordability, all to assess access through this combined lens. In the early and latter halves of the 2010 decade, which is what we compared, the proportion of Americans who lacked access to timely, high quality, and affordable surgical care was around 1 in 3. But over time, the reasons for why they lacked access actually changed. For example, a growing proportion lacked access, as you can see in that figure, due to timeliness, may be secondary to things like hospital closures, although decreasing proportions lacked access due to issues like affordability. That may be due to Medicaid expansion and the Affordable Care Act. These findings, in our minds, underscore the importance of studying access through a multifaceted lens in this way to truly understand access. But kind of spinning back to rural, we found that rural patients were around 4 times more likely to lack access to surgical care that is timely, of high quality, and affordable. Now, digging into the timeliness piece a little bit more, we looked at 16 different inpatient surgical procedures spanning both common, lower risk procedures and high risk surgeries that are more complex in nature among rural Medicare beneficiaries, and found that nearly half, over 44% of Medicare beneficiaries to be specific, are driving over an hour to obtain surgical care. And that timeliness gap is getting worse over time. Even for some common operations like those that we've been talking about, nearly a third are traveling over an hour to get their appendix removed, over 40% for a hernia repair, and over a third for gallbladder removal or colon resection. And we know that timeliness of surgical care, especially in the non-elective setting, has important implications for surgical quality and outcomes. Longer travel times tend to lead to higher disease complexity in the emergency general surgery setting. And those with longer travel times have higher rates of transfer to higher levels of care. They're more likely to fail non-operative management for surgical conditions that are sometimes able to be treated without surgery. And they're also more likely to need to be admitted rather than be managed in the outpatient setting. Now, changing gears a little bit, there's this phenomenon among rural patients that we call hospital bypass, which is where rural patients are traveling farther than their nearest by hospital to obtain care. In the world of surgical care, the rates of bypass that have been described previously are quite high across both common and complex procedures based on more limited HCUP cohorts. And this work has also found that traditionally underserved patient populations are less likely to engage in bypass behaviors. In our own work, we've kind of expanded our understanding nationally of this rural hospital bypass phenomenon and found that around half of all rural patients are bypassing their nearest surgery-capable hospital to obtain care at a significantly more distant facility. And interestingly, we found evidence to suggest that rural patients who bypass actually have worse surgical quality than those who do not bypass their nearest surgery-capable hospital. One thing that kind of surprised us in doing this work was that even for elective surgery, those who bypass actually had worse surgical quality. Now, I know we're focusing on quality for patients at this point, but I want to quickly jump back to the hospital level here and the challenges they face to make one quick point, which is that one of the principal struggles and challenges that rural hospitals face is one of volume of care provision. While many existing models are not perfectly crafted to account, perfectly for appropriate instances of bypass, there are emerging data like this paper that came out just a couple of months ago in JAMA Open that underscores the potential hundreds of millions, if not billions of dollars that are being left on the table for rural hospitals from a spending standpoint as a result of rural hospital bypass by rural patients. Even if we were just using our model of rural hospital bypass, specifically looking at common surgical episodes, which we know can be delivered safely in the rural hospital setting, even conservative estimates would suggest that the average rural hospital is leaving hundreds of thousands of dollars on the table of Medicare spending alone as a result of bypass, which is substantial for hospitals' revenue. All right, back to rural patients. Despite the previous hospital level work that I showed you, the bypass data would suggest that there's likely a large group of rural patients that are unaccounted for when we only look at rural hospitals. So we recently looked at a more contemporary cohort of Medicare beneficiaries through the calendar year 2023 and over 400,000 rural beneficiaries who underwent common general surgery procedures. And after risk adjustment, we found that rural residents was independently associated with worse surgical outcomes. These data kind of unveiled a paradox recently to me and to our team. We saw earlier that even the smallest and lowest resource rural hospitals are capable of providing high quality surgical care for common conditions. Yet rural beneficiaries in general tend to have worse outcomes. But when we stratified these data by facility type, where the beneficiaries obtained care, we still found that rural folks had worse outcomes regardless of the facility type they went to. And so we think these findings may point to some important upstream structural barriers and issues and challenges with care coordination that may be driving some of these data. Now, some co-residents of mine who have content expertise in the area of studying race and ethnicity in the context of surgical care want to kind of approach me with this idea of evaluating whether rurality combined with race or ethnicity minority status constituted a double dose of health inequity among our surgical patients. We found that non-white rural patients had significantly worse outcomes than rural white patients across most measures of surgical quality. And to be clear, while the non-white composite comparison was one analysis that we did in this study, we compared each specific race and ethnicity group that Medicare claims abstracts and identified similar findings across all of our study groups, although the highest disparity subgroups were Black patients and Native American and Alaskan Native populations. Now, you might be thinking that these overarching disparities have been described previously, but then we looked specifically at the difference in disparity based on race and ethnicity in rural versus urban America and actually found that rurality was an additive disparity from a mortality standpoint specifically. So these data suggest that race and rurality compound with one another and have an additive detrimental effect from a mortality standpoint after undergoing common inpatient surgery. Now, others have done really important work to describe the challenges that rural patients face in obtaining equitable subspecialty surgical care compared to their non-rural counterparts. But one unique challenge for care like thoracic surgery care and vascular surgery care and heart surgery is this type of subspecialty care just generally isn't available locally for rural patients. And so it hasn't necessarily been a strong area of interest for our group just yet. But to summarize, rural patients face major barriers to obtaining surgical care. They're more likely to lack access, travel long distances, experience delays. These gaps translate into worse outcomes, especially when patients bypass their local hospitals or face compounding disparities like we identified among race or ethnic minority rural patients. Stepping back again to the topic of rural health policy, we're facing a number of different policy headwinds, each of which could probably be a talk in and of themselves that I won't heavily dwell on here. But whether we're talking about surgical care or rural hospital sustainability more broadly, the message is the same in my mind. We need coordinated, intentional strategies For surgical care, this spans the pipeline, training, selection, readiness, team support, mentorship, and policy alignment. And for rural hospitals, the same idea applies across program design, payment and reimbursement structures, administrative burden, and the care delivery system more broadly. So to close, I would say that we could look at some of these troubling data in one of two ways. One, we could feel overwhelmed by the Herculean task to work towards improving rural health, or we could just slowly and intentionally start chipping away at this massive stone, where there are an infinite number of opportunities to work towards aligning the policy environments to slowly work towards the construction of a system where healthcare facilities are resilient, the workforce is supported, and we can reach each rural patient to give them and provide them with high quality surgical care. Um, I wouldn't be able to do this work without the folks that are on the screen from my mentors, Drs. Ibrahim and Dimmick, who live in the ivory tower with me and are OG health services researchers, as well as Dr. Jan Probst, who is like the matriarch of rural health services research from South Carolina. But the most two important people in the team, from my standpoint, are doctors Westphal and Bredbeck, who have dedicated their clinical lives to serving rural patients as primary care doc and a rural surgeon, who keep our work in check with clinical care realities, and they keep our research questions grounded in working to incrementally improve the care of actual rural patients and kind of understand actual rural problems. This is my email. I'd love to hear from you guys. I'll warn you, our two golden retrievers, Lucy and Bo, run my inbox, and their lack of thumbs to message back quickly can be a problem. But our 3-month-old daughter, Millie's whipping them into shape a little bit. So happy to take questions and excited to hear from Cody.
Thank you, Dr. Mullens. I'm going to get my dog to run my inbox. That's an excellent strategy. And I love Millie's name. I have a Millie as well. Good name. Okay, so please do put your comments and questions in the chat, and we will bring those up during our moderated discussion in just a few minutes. But before we get to that, it is my pleasure to introduce to you Secretary Cody Kinsley from Wilmington, North Carolina. Cody is a first-generation college student and currently serves as a senior policy advisor at the Johns Hopkins University School of Nursing. Cody served as North Carolina's 18th Secretary of Health and Human Services, and throughout his tenure, he focused on making healthcare more affordable and more accessible for all North Carolinians, including those in the underserved and often overlooked rural areas. Cody played a pivotal role in expanding Medicaid in North Carolina, resulting in over 600,000 North Carolinians gaining healthcare coverage in the first year. He implemented North Carolina's groundbreaking Health Opportunity Pilots. It's the nation's first large-scale experiment proving that paying for non-medical health needs like food and housing improves health and lowers cost. In partnership with all of the state's hospitals, Cody provided $4 billion in medical debt relief for 2 million North Carolinians. His career includes roles at the White House, the U.S. Department of Health and Human Services, the U.S. Department of Treasury, where he was appointed by President Barack Obama and continued under President Donald Trump as Assistant Secretary for Management. We are glad to have you, Secretary Kinsley, and audience members continue to put comments in the chat. Take it away.
Well, thanks so much. It's wonderful to be here with everyone. And I'll just have a little bit of a confession. My entire life, I've pronounced Dr. Mullens' name Sody as an effort to differentiate from the appropriately spelled Cody with a K. So, add that, Carrie, to the fact sheet of the correct pronunciation. Perhaps also showing a little bit of the chip on my shoulder of my mother wanting my name purportedly to be more masculine with a K, which I think maybe backfired later in life. But nevertheless, it's great to be with all of you today. And my dog is behind me sleeping. He will not answer your emails. So I thought Dr. Mullens did a beautiful job really setting the table of the challenges that our rural communities face. And I always like to start there, which is that we're talking about people and broader demographic dynamics and what's happening in these communities, and that the folks who live in rural communities across this country want the same thing that everybody wants, which is to have the tools to be healthy and well, and to live lives of abundance and joy. And we have a health system that has been built, frankly, to serve more urban and dense spaces, and our rural communities are left behind because they don't face the same dynamics, the same shapes and sizes. And I think, as Dr. Mullens shared, most of our efforts to kind of adapt a high volume based fee for service model in delivering healthcare to serve more sparsely populated areas with different dynamics have really been kind of paperclip and scotch tape additions to sound health policy. And so, as opposed to sound health policy. But I want to zoom in a little bit in particular in my remarks, and I'm going to just speak and then looking forward to the discussion on the Rural Health Transformation Program. And so let's start by getting in our kind of Back to the Future car and remembering how this unfolded, because I think the origin story is really important. So as Congress last year was working on what is now HR 1, formerly, or maybe also known as the One Big Beautiful Bill Act law, which is now law, or I call OB3, so all those names. OB3 was getting debated. A lot of hospitals stepped up and said, look, our rural hospitals disproportionately depend on Medicaid. The impact on the various changes you're making with work requirements / community engagement requirements are going to likely reduce coverage in rural communities. Rural hospitals, from both those changes and from the changes being made to this thing called state-directed payments in Medicaid, is going to kind of in total pull out $1 trillion out of the healthcare system over the next 10 years. And we're going to see a disproportionate impact in rural communities. Our rural hospitals are going to face that. We had a couple leading senators, senator from Arkansas, senator from Maine, who were very forward about the need for funding rural communities specifically, with an eye on the impact that HR 1 / OB3 was going to have on those rural hospitals. So here was the birthing story of the rural hospital, or the rural healthcare. I actually just did the mistake. The Rural Healthcare Transformation Program, which was for $50 billion. Now, first off, for those of you keeping track at home, that math ain't mathin'. 50 billion is not a trillion. And so those dollars don't really add up as far as a true pay for replacement. And that has been the primary obstacle that a lot of folks have had in trying to even begin to accept that there's any good that can come out of this. Well, my spoiler is I think there is good that can come out of this, but it's still going to be a big headwind. And you can't look at it as a trade-off, even though that was the origin story. The second thing, which is the kind of mistake that I just made, is that while the origin story was really about how hospitals were getting impacted by OB3, this program was not really, it may have been legislative intended for hospitals, but they gave the federal government, and particularly Dr. Oz, the administrator of the Centers for Medicaid and Medicare, a significant amount of flexibility to shape this program however he saw fit. And what the administration shaped was an application that came out, mid last year, that really was not focused on hospitals at all. This was an application that asked states to put together their ideas on how best to invest these dollars in what I would call kind of systems and care transformation. And we'll talk about what some of the states focused on in just a moment. But just to get a sense of the numbers here, each state was guaranteed $100 million just for completing an application. I mean, those are my kind of odds, especially if you live in Rhode Island. And that sounds like a good deal. But if you filled out an application, you turned it in, it was complete, you were going to get $100 million. For those dividing the dollars, it's 50 billion over 5 years, 50 states. Unfortunately, tribes were left out. Our various other spaces like Puerto Rico or Guam, they were also left out. And so there were some kind of problems out of the gate there. So the second potential $100 million that each of the states could get were what I call the bonus bucks. And these were dollars that were going to be based off the merits of their application and other particular items that they put forward. For those that know Mark Holmes at the Shep Center at UNC, he's done a really good job of showing kind of some of the analysis here of which states got those bonus dollars. So bottom line is states were going to get at least 100 million, potentially 200 million or more, depending on how good their applications were, how rural their states were. States had about 60 days to come up with a strategic plan to transform rural health for the future. I mean, I'm like working on a housing renovation right now. I can barely get an appointment with like the architect people in 60 days, but nevertheless, a lot of folks worked really, really hard around the clock to try to put that forward. And I want to note that there was a lot of flurry in that moment, right? So think about a state like North Carolina, 11.6 million people. We claim to have the second largest population of people living in rural communities in the country, second only to Texas. And trying to do appropriate stakeholder engagement, to talk to the folks in those rural communities, to get input from on the ground, to do that in 60 days, to turn in a thoughtful, 62-page application, coincidentally. Really, really challenging, but I think folks did their best, as did every other state. Then the federal government, this is my favorite fact, took longer to review the applications than they gave the states to complete the applications. And they would give kind of the final award tallies by essentially midnight on December 31st of last year. States then have had the first 2 months of this year to kind of go back and forth with the federal government to finalize their ideas on exactly how they would spend the money. And states really only are starting to get dollars now. So some states started to get money in March of this year, right at the end of February. Some states are just now getting allocations. And those awards ranged from 147 million was the smallest award to 281 million. 281 million to Texas, 272 to Alaska, that was number two, 213 to North Carolina. And that's the amount of money just for this year. There's no guarantee of how much money states will get next year. And so, states are working hard to try to implement money. Just a few more comments on this, and then I think we can go to questions and discussion. What are the broad themes that we've seen states trying to invest these dollars in? First and foremost, technology and trying to transform care delivery, technology in the form of wearables, which are very popular in this administration, technology in a number of different ways. We've seen a lot of workforce investment as far as trying to upskill community health workers, extendable workforce strategies. Some work around value-based care and what does that look like from an adoption perspective and supporting rural communities, data-driven care coordination, broader service integration and access. So again, no real hospitals. Some states have figured out a way to do some uplift to hospitals, but generally there have been, mostly sort of around the edges there. The last thing I'll say on the money, which I think is really important, and then a few summary thoughts, is that the dollars have to be obligated by September 30th of this year. So they're getting the money now. They've got to make sure all their state contracting processes are done and money is obligated by the end of September. And the competition for next year's dollars will have already started. So final thoughts on this. One, I think that the application actually shaped out a really nice transformational strategy. Like the things that we need to invest in and we need to figure out is how do we pay for things differently in rural communities so that they actually work? Because the idea of paying for them the way that we pay for them in urban spaces isn't working. How do we continue to push back against legacy fee-for-service problems? How do we leverage telehealth? How do we support on the ground things that make people healthy to prevent the need for high cost care, et cetera? And so I think that there are some real promises here. And I think there's a lot of good efforts at states, even with the headwinds of the amount of time they've had to do it. But proof will be in the pudding when the rubber hits the road, and states are working on a very short timeline and very aggressively. And I think we'll see lots of learnings in year one, and hope that year 2s through 5 are a little bit more stable for folks to work on. And that is the Rural Health Transformation Program, and looking forward to the discussion.
Thank you, Cody. So, over the course of these two talks, we have gone from in the weeds and looking at how far individuals are driving for care by passing different hospitals, quality of care for high volume surgical procedures, all the way to the 10,000-foot view of $50 billion being administered in a very short timeline to states who now have to do the work of spending and seeing outcomes. So with that, please do continue to put any questions into the chat. I will start us off with a question going back to Dr. Mullens. I was really fascinated by this situation with bypass, right? And people driving past a local hospital. But I started to think about how that would play out. Like I always think of the narrative in my head, right? And I thought about patient preference. So I know in my family, hospitals build reputations, some of which are earned, and some of which are just truly family lore about, who died where and different things like that. Because inherently, there is distrust oftentimes of hospital settings, in particular and a lot of individuals who live rurally. It takes a lot to live rurally. You have to be very self-sufficient and independent. It doesn't mean that they don't need care. It's just a mindset that I think is very prevalent. So, do you have any information, or is there qualitative data that actually comes from rural patients to help inform what is driving some of this bypass behavior, particularly when it looks like outcomes are not good when this behavior
Yeah.
is.
Yeah, so it's a great question. I was as you were asking that question, I was reflecting on a conversation that I had with a reporter who reached out about that health affairs paper recently, and they're like, "Okay, so like, what are your policy recommendations?" And I was like, "I cannot give policy recommendations right now, right? Because we don't know why this is happening. We don't know if it's like referral patterns from physicians of their patients who need surgery and surgical evaluation. We don't know if it's narrow networks that are driving patients in a certain direction." Especially because we're studying Medicare, right? So maybe some MA narrow network stuff or Medicare Advantage narrow network stuff. Or is it patient preference, to your point? Um, so we don't know. It's like a relatively small group of people who study this phenomenon. And we were, the surgical people at least, we were kind of at the meeting, kind of like doing the Spider-Man meme of like pointing at one another, like who's designing the qualitative study so we don't like, so that we can actually understand like why this is happening, not just understand its clinical implications and the extent to which it's harming rural hospitals. So I think that is like the absolute logical next step before you can even think about whether there are potential policy solutions to the what we think is might be a problem. Because to your point, um, you know, and I think like especially for the work that we do on a more national level, it's like rural is so different everywhere, and the rationale behind which patients are bypassing is going to be so different everywhere. And I've spoken to a lot of I've connections with a lot of clinical rural surgeons, some of whom, some will like take over a practice where like everyone like loved their local rural surgeon. They would like, show their surgeon their incision in the grocery store kind of thing, and like showing my hernia in Kroger or whatever. Um, and so like inherently, like when you are the surgeon taking over that practice after that surgeon retires, everyone's coming to you for their common surgical issues. I've also talked to other surgeons who, inherit a practice where for the past 2.5 years it's been locum surgeons. Not that there's anything wrong with that, but there's never been like a stable figure who is like the surgeon, the country doctor helping take care of me in my community. Um, and the two surgeons who were there for longer periods of time before that like weren't really highly trusted. And so yeah, in that place, like everyone's bypassing that hospital and going elsewhere. um but so it's a great question, great point, and like the most important next step of this kind of work related to bypass.
Well, I'm glad you all could put quantitative data behind the problem to first say there's a problem here, right? Like that's the first step, nationwide level, state level, whatever it can be. So then people can start digging into the why. Arpitha joins in on the chat and notes some curiosity about the role of insurance with clinical care access. So I think this is a good question, perhaps, for Cody Kinsley. I I repeat the rights. I know it isn't black and white, but does it further restrict people in terms of access? For example, the furthest hospital has some coverage, but the closest hospital has less coverage. Does it improve the situation in one way? I guess the overall question is, how does access through insurance, right, or other forms, Medicaid, which you're very knowledgeable about in the expansion, how does that perhaps weigh into where people are seeking care?
Yeah, this is an interesting one. So first, you know, by and large, in most rural communities, primary payers are going to be, in expansion states, Medicaid, um, Medicare, and then usually if the state has some sort of state health plan, think of teachers or other state employees. So for most rural hospitals, those are going to be big payers, one, two, and three. Depending on how diversified your insurance market is, and for the same consolidation drivers that Dr. Mullens outlined around hospital care, there's similar consolidation happening in the insurance markets. Um, and also because of network adequacy requirements, especially in the managed Medicare and managed Medicaid space, usually there's not a whole lot of issues, at least in my experience, and happy for Dr. Mullins to disagree as far as people being forced to drive, being that, that being a driver of the bypass piece that he was describing. But I think it is something that is kind of worth describing are worth looking further into. The one thing I would also add here, just to reiterate on the Medicaid piece, what we knew in North Carolina as we were working towards Medicaid expansion was that people in rural communities were 3 to 4 times as likely to be uninsured compared to their urban counterparts, right? You think about the dynamics of who's able to offer health insurance, usually larger employers, or people are buying it on the marketplace because they're able to afford it there. People in smaller communities are often working for themselves or in smaller businesses that don't offer health insurance, like our daycares or our small downtown businesses, and which is why Medicaid expansion was particularly important in those communities. And so for those now roughly 10 states that still have not expanded Medicaid, that is a real drag on those rural hospitals' abilities to serve people and for folks to have access.
Mm. Emily Johnson has an interesting question here too that I'd love to hear from Secretary Kody and Dr. Kody. Secretary Kody, if you can talk about how what you're seeing in some of these applications that came in from the states for the rural health transformation, the risks that you're worried about for fast AI adoption in health and healthcare. Are there risks that you think might be specific to rural communities when you're seeing these applications and common themes talk about, expanding access through AI or other technologies? And then, Dr. Mullins, from your perspective on the ground, do you see ways that AI can be used to improve either access to surgery, surgical outcomes, et cetera, in the rural setting? So, Secretary Kody, do you want to start?
I think that, hot take, in healthcare, the AI arms race has already begun. And when we look at hospitals and we look at payers, there's rapid adoption of AI on the administrative side of things. Either strategies to drive appropriate charge capture, strategies to try to modernize prior auth. So a lot of the kind of stuff that patients don't ever see that, I mean, and frankly, hospitals are doing that. I do think there's an interesting gap here, and I credit my friend Q Ree, who runs the National Community Health Center Association. He often references that our federally qualified health centers, our community health centers lack equity. They don't have the same technology backbone and infrastructure to try to support population health issues, identifying and achieving HEDIS measures, supporting patients and patient access, being able to use the app, etc. And that is a gap. I am hopeful actually that the rural health transformation dollars will try to help through some of those community health centers solve some of the tequity issues. I think that the mishaps that AI will drive in the dynamics of healthcare are already kind of being pushed because of the financial incentives in healthcare. And I don't think that we'll have our thumb on the scale in a negative way necessarily just from the rural health program.
Dr. Mullens?
Yeah. I have complex thoughts about AI, especially I think on its face, like there's no better time to be a rural hospital in like thinking about how can I like advance the technology, the IT in my hospital, or maybe like adopt some of these higher fidelity, AI things to like help improve charge capture, billing, like all those things. Because they like might have the money to do it with the Rural Health Transformation Fund. So it is like a unique time where like AI, clinical AI things are taking off as is like this policy lever by which rural hospitals, because they're all 40% of rural hospitals are operating with negative margins currently. Um, in a normal setting where there's not $50 billion of the federal government's money sitting around, like there is no realistic opportunity for a rural hospital to be investing in technologies like these. They're just like trying to keep the door open to take care of their patients. So I think in theory, there's legitimate opportunity both to like modernize, but in my mind, before going to like AI algorithms, aside from the administrative side of things, because one thing we know is that rural hospitals don't upcode patients. Like they're not the best at like capturing all these comorbidities of patients, and so there are real potential opportunities to like get better reimbursement for the care that they have already been providing through some of these tools. But I think from a tech standpoint, the best part of like the best place to spend money will be in like telehealth and being able to like remote in expert consultation, like to help with a patient who gets sick and might need ICU or like a higher level of care in general. Or to like when I think of surgical care, I think of injured patients just because like that's the most common thing that happens that we as general surgeons deal with. And I see it in Michigan all the time where a patient, has an ATV crash up in the Upper Peninsula of Michigan, and they get shipped all the way down to Ann Arbor because it's a level 1 trauma center. They take an ambulance and a long helicopter ride to get to us because they had like bad facial fractures. And then the OMFS surgeons see the patient and they're like, oh, we'll deal with this on an outpatient basis. Like they're good to go home. And then you send them right back up to the Upper Peninsula 48 hours later. There are real opportunities to improve clinical care through telehealth and things like AI detection for injuries and expedite timeliness of care if you have AI algorithms that can do quick prompt reads of CAT scans and get those sent out to providers if you're worried about a stroke or looking at an EKG and worried about a heart attack, things like that. So I think there are some real legitimate opportunities, but the proof will be in the pudding in the next few years of how that money gets put to use, because the cynic side of me like knows that I just talked to an intuitive rep at which is like the big robotic surgery platform that a lot of hospitals now have. When you think about having a robotic hernia repair, gallbladder removal, that is like what gets used. Um, I was at the North American Rural Surgical Society meeting, and like the reps there were like trying to pull aside every surgeon and asking if they have a robot in their hospital and being like, let's get a robot in your hospital with this $50 billion. And I'm not going to jump
Right.
down that rabbit hole, but I'm happy to talk more about it. But that is not a good use of a hospital's money.
I'll just tack on to that. I mean, that's the other frame here, which is like this $50 billion by all of the vendors has already been spent 10 times over.
Yeah.
And so there's been a lot, and I think that's part of what will be a flurry this year around those dollars.
Yeah, I mean, that was the one thing I was hearing, that all of these vendors were like, there's $50 billion coming. We are going to contract that hospital. And, to your point, Secretary Kinsley, to have a 60-day turnaround on a strategic plan like that, it's very attractive when you have a lot of people knocking on your door and saying, let me get you this. And, you just have to purchase this and we can do all these things. That must have been incredibly, incredibly stressful to put together something like that. And I agree with your just, praise for the states to get in there and do their very best to figure this out and submit an application. Greg, you had a question. Go ahead.
Yes, yes. First, thanks. Great tag team. You guys should take this on the road, other places. It's a nice balancing.
We both have blue shirts and gray blazers on too.
There you
There might be
go.
some like real synergy here.
There you go. There you go. I wanted to visit the workforce issue, and maybe I'll ask Secretary Cody first to sort of, you alluded to some of the components of the individual state plans for workforce, and I bet everyone has checks the workforce block, but there's some sort of very broad characterizations of what those constitute, and then get reflections from Surgeon Cody, recognizing the political dynamics of mid-level providers and family medicine and the dynamics of, you know, the right people to do the right procedure or provide the right care at the right time. Yet, like the surgeon who drives around and spends Monday in Salisaw and Tuesday in Tahlequah, like you travel to each of these different places, sort of what is the right kind of model? Because I think you had touched on it, like you lose that connection with the community when it's already hard to get people to go practice in rural situations. I'm not sure people are lining up to say I'm going to be a traveling doc. So maybe start with the big picture, Cody.
Sure. So one piece on the big picture that actually dovetails into some of the political dynamics is one of the aspects of the application was that, do you remember the bonus bucks that I talked about? So states were eligible to get more of those bonus bucks if they had already or were on path to adopt a number of quote unquote supply side reforms around healthcare, specifically if they were to allow advanced practice nurses to do independent practice without supervision, if they were to make a series of changes around certificate of need laws. And we could probably spend, I don't know, the rest of today, tomorrow, and next week debating just those two issues. Like, I've never been almost murdered by nurses and almost murdered by doctors enough. Anytime I walk onto that, my approach in governing is to piss everybody off equitably. And so I think that there was a significant push on the scale just for those two things. And so I think we will see some states aggressively changing the rules of the road around that, which will have an impact one way or the other on the workforce front. But second of that, what did states do actually with the money? So there's a lot of focus on of kind of a grow your own strategy. How do we start in middle school and high school and identify individuals, rich for the pipeline, people who grew up in West Virginia who want to maybe one day come back and work in rural communities in West Virginia? What we have found over the last several years through a number of rural residencies and student loan forgiveness programs, is that, unless you're really from the area, most people don't want to stay. And so what are all the things that you can work to try to help support someone to stay? And having roots in a community are really important. And so as opposed to leaving those roots and never coming back, how do we help you come back and then stay? And so this kind of grow your own pipeline is really key. But then that also has to work with, with the way we train physicians and psychologists and social workers and other folks, is really team-based medicine, right? We're working. You've heard me talk about better coordinated care and integration, and Dr. Mullens talking about technology and how people work in teams and all of that. And so, to your point, Carrie, like the idea of Dr. Haslett from Murder, She Wrote walking around doing everything with the black bag, like that doesn't work anymore in rural communities. And so we can't just do the retention strategy and the recruitment strategy for the doctor. We've got to build out what's the entire scope look like to help support something that can get closer to whole person care, and how do you augment that with technology? So really thinking about workforce, broadening the care team. There are some programs specific to loan repayment to augment things that are happening there. And then also a lot of workforce development for what I would call paraprofessionals, whether those are peer support specialists, direct care workers, community health workers, folks to try to help support health and to leverage trust in community to connect people to care that are also very important and a significant amount of evidence base there.
Great. Such as Maryland's Public Health Service Corps is part of our state plan. Cody, the other Cody.
Yeah. I am I think my simple take on like who should be providing what clinical care, independent practice for APRNs. My take is simply that everyone should be practicing at the very tip top of their license that is appropriate for them to provide care. I mean, in the surgery world, like we don't feel encroached by the family medicine doctors that are doing endoscopy. Like the family medicine doctor that's doing endoscopy is providing an immensely important service to the patients that they serve and to the hospital that they work at because that's extra revenue for the hospital. So that's my like very brief short take on that. Um, in the surgery world specifically, we're facing like massive crisis, frankly, from a standpoint of the workforce. Rural surgeon workforce is quite old. They're retiring at like the rate at which they are going into retirement and we are training rural surgeons aren't even like in the same stratosphere as one another. You couldn't plot them on the same chart. Um, the to Cody's point, like the most important thing in my mind that we can be doing for the longer term is developing these pipeline programs where we are identifying people who are going to actually go into rural practice. And to Cody's point, the most important, like this is true in like every sector of medicine and surgery. The most important predictive factor of going into a clinical rural practice is rural background. It doesn't necessarily mean that you have to like have grown up in Weirton, West Virginia to be like the person to go back there. But the only type of person that's going to go back to a place like Weirton is going to be somebody who has some type of rural background. Because most people tend to like stay within about a 90-minute drive time or so of where they trained. Um, that being said, I do know this is like the absolute rare like case example that is not necessarily something that I think should be replicated in a lot of places. I know a very unique guy who went back to his hometown of Rensselaer, Indiana, and covers the 4 critical access hospitals in his surrounding area and is like loved by his entire community because when a patient needs something at one of those 4 hospitals, he goes into the backyard of his farm onto his helipad and flies in his helicopter and parks in the hospital parking lot to take care of that patient. Which is just like a fascinating case example that I love to throw out there about a guy named Randy Lehman. But that is the exception, not the rule.
Doesn't sound scalable.
I
Well,
don't
maybe.
disagree.
I mean, there is space for helipads. I mean, I wouldn't throw it out right away, right? Like maybe. And honestly, I can think of a lot of people who'd be like, "Oh, I get to learn how to fly a helicopter and use that." Yes. Um, but I want to just, I know we're close to the end of time, but I would also love your thoughts regarding workforce. When it comes to individuals who are on different visas, because we know a lot of our workforce, particularly in rural environments, are individuals who are in the United States with professional visas, whether that be for nursing, for physician care, for surgical care. Thoughts on how that pipeline may need to be reinforced, bolstered, or perhaps thought about?
I don't know what Cody that was for, but you know, I think that there is a lot of broad debate and discussion right now at the national policy level about these visas, and yet our country has a very, 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 very long history of leveraging these visas to augment the healthcare workforce. My partner is Filipino, and every single person in his family is a nurse. And there is a long history of that. And I think that you know we just don't have the demographics in this country to solve this problem. I think with our own, um, with training our own folks, we're going to have to bring more people here, and so I think that this issue is going to get even more at a rub from a public policy perspective in the coming years.
Yeah, I was just trying to dig it up. There was a JAMA research letter that just came out last week on this very topic, looking at surgeons specifically sponsored H1B visas in the United States. And they have a nice map in there that demonstrates where those people work. And they are in all the rural places. Like we need them. They need to be an important part of the strategy going forward. It needs to be something not that we're fading on or ostracizing, but rather doubling down on.
Mhm. I mean, that is the one thing that keeps me up at night and thinking about the care where my family goes, right? The fact that if we do not continue to have the opportunity to work with these wonderful folks on visas, we're really going to see like really concerning, even more concerning disruptions to accessing care. With that, we are near the end. Greg, would you like to wrap us for today?
Oh, well, first, let me thank Carrie for successfully moderating the session. Thanks to everyone for participating. We will certainly circle back. Again, this is part of an ongoing discussion that we hope to continue and really to grow both the number and depth of people engaged in rural health. I put something in about there's not a lot of money directed to evaluation. And if you think about evaluating programs, like we have extensive expertise in that area, and we welcome suggestions from both Codys about how we could move forward in 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 evaluating what actually works with these investments to try to make the appropriate decisions moving forward. But with that, let us thank Cody and Kody. You guys did a great job. We really appreciate it, and we look forward to continuing the discussion. Thanks, everyone.